and next 10 years or 20 years or whenever I fall sick, I hope we'll be able to make use of all this clever technology which has been developed. We all know this, that we are a poor country, we have limited resources, there aren't that many doctors, there are just too many patients. I think part of the problem with this is, and it's a bit ironic, you sit in an air-conditioned 5-star hotel and you have these fancy conferences talking about stuff like this, whereas when this is your target population which we're talking about. And this, I think, still remains a big problem. Will patients accept telemedicine? And even in my own practice, patients aren't happy unless they actually come and talk to me and they see my face. And in all the reality, I actually tell the patient, don't come to my clinic, don't telephone me. I'd rather you want to talk to me, do it by email. Everything is documented, it's in black and white, it's much easier for me to reply. Fortunately, infertility is not an emergency situation. It gives them enough time to think about their questions. It gives enough time for me to craft my answers. And most of these are questions I've heard before, so often it's quite easy for me to copy and paste. So just a simple application, like just bread and butter basic email, is such a simple telemedicine application which I use every day. But part of the problem is that patients need to be educated. They kind of feel, do I need to see the doctor? Will the doctor understand? In reality, for example, even if a patient comes to my clinic, these days with infertility, I don't even need to do a physical examination because lots of medical treatment today depends on laboratory investigations or tests. So for example, a urologist will be even more interested in what the ultrasound examination of the kidney and the bladder shows rather than actually physically examining the patient. So they're often treating patients today based on lab reports or scans. The question, of course, is what will this do to the doctor-patient relationship? Does anyone have any feelings about this? Do you think doctors will become impersonal, will become widgets, patients won't care anymore, we'll all become, your Dr. X, the Dr. Y, or Dr. Z? Does anyone have any feelings? Because you're doing this through telemedicine, you're doing it through looking at a face on a screen, you're no longer actually walking into a doctor's clinic and actually seeing the doctor. I actually think it will help to enhance the doctor-patient relationship. I don't think it will detract. And the reason for that is even today in reality, you will spend anywhere from 2 to 3 hours waiting outside the doctor's office to see the doctor for literally a 2 to 3 minute darshan from the doctor, because most good doctors are extremely busy and that hardly creates any satisfaction. Whereas I think it's possible to use a lot of this technology to help to improve the doctor-patient relationship. And that's what I'm going to talk about. But I think this is my most important slide. I think all the time we keep on thinking patients are the problem, there are too many patients don't have enough money, how do we get hold of them? And I think in reality, patients are the largest untapped healthcare resource. Part of the problem is we look at patients incorrectly. We think of patients as consuming healthcare resources. Actually, we need to remember is that patients are actually the providers. And because we're all doctors, all we think about is what we provide as medical care is when the patient comes to me and this is when I treat the patient, that's the medical care. But actually over 80% of healthcare is actually provided by the patient. And that's true even today. Even today, you're the one who decides when you want to go to a doctor, which doctor you want to go to, whether you're happy with your doctor or not. And I think lots of these opportunities exist in India simply because it's such a broken system right now. Fortunately, we're in a demographic sweet spot. There are lots of clever doctors, lots of clever entrepreneurs. But I think the important thing is we need to focus on these opportunities and we need to look for solutions and not for problems. And we also have these great 7-star hospitals in Bombay. The fact is, I think the problem today is that patients are not happy with their doctors. Doctors are too busy, or doctors just want to do tests. They kind of over-prescribe, over-treat. And what really patients want is the old-fashioned, what they used to think the family doctor of the past who knew everything about you. But unfortunately, that doctor has gone away. I just need to remind you that all of us are on the same side, that we don't need to create this doctor versus patient confrontational relationship. We need to start creating win-win situations. And I think the best way of doing this is what I believe is called the positive deviance model. You look for success stories and then you scale up these success stories. This is the most important slide, is that we patients, when I'm sick, for example, the first thing I don't do is pick up a phone and talk to my doctor. I don't look up at the web or whatever. I still make a lot of these decisions for myself. I think the important thing is that we need to empower patients with reliable information so that when they make these decisions, they're sensible, right decisions rather than unreliable information. And the key question we need to ask ourselves is how can we as healthcare systems educate and empower our patients with information so that they make the right decisions. This is a very simple thing, which actually amazes me why more people don't have. Why shouldn't every hospital have a patient education resource center? You have all these patients who are waiting for their doctors. You have all these patients' relatives who have hundreds of questions about what's happening. You have all these doctors who are too busy to talk to patients. Whereas if you had a place like a patient education resource center, a lot of these problems would be solved. And equally importantly, this is what our big goal is. We think every doctor should have their own website. There is a one-time cost. You know, people say doctors aren't savvy enough, how will they do it? But I think doctors are reasonably bright. The great thing about once the doctor has put up the website, a lot of communicating information to the patient, all the problems go away. The patient trusts me. The patient doesn't trust Google, but the patient trusts me. So if the patient comes to my website, which is drmalpani.com, the patient knows the website information is reliable. My job as a doctor is to make sure that I provide reliable information. And the great thing is that I'm providing a win-win situation. It's good for me as a doctor to have a website. It helps me to attract patients. I'm willing to update it and spend time and energy. And it's obviously good for my patients as well, because then they can reach out directly to me rather than to have to go through a middleman. So it helps to encourage trust and reliability. This is what websites help to do. It actually helps doctors to become more empathetic. Because you're creating a website for your patients, it helps you to look at things from the patient's perspective and the patient's point of view. A big criticism about a lot of the websites today is all the information is in English. And there's much more information on mayoclinic.com than, let's say, apollohospital.com. And actually, I think that's an opportunity. If I were a general practitioner sitting in Surat, I would put up a website which would be in Gujarati for my patients. And these days with a flip camera or with a mobile, it's not very hard to, you know, just videotape a consultation. And suppose I were a pediatrician, I'd take the 20 commonest problems which I see in my practice, diarrhea, failure to put on weight, fever, whatever else, and I just have a conversation and then put it up on YouTube, and then anyone in the world could watch. And I'm not depriving myself of my patients, because any patient who then decides they still want to come and see a doctor are much more likely to come to me rather than to come to someone else. So these are all easy, inexpensive things to do. But even better, I think, once you have these websites, you then have patient portals, and then you're allowing patients to share information with themselves. And let me tell you one thing, every good doctor will tell you the only way to learn medicine is from your patients. Unfortunately, patients aren't articulate, or doctors are too busy to listen to patients, but the moment you're opening up these channels of communication, there's so much more information coming in. So we really need a bottom-up approach, listen to my patients rather than the other way around. And that's all about what I call listening to the patient, or giving patients a voice. Patients have blogs. There are great sites like Patients Like Me, where patients actually record what's happening to them. And it's a great way for doctors to learn about what patients actually experience. And of course, it allows them to rate doctors, and which is good. You know, it's good for doctors to be disciplined, because if you're rude and an unhappy patient thinks you're rude, they're going to tell the rest of the world about it. So you're going to be on your best behavior when you're talking to patients. And that's the book which we've written, which basically summarizes that we need to use what we call information therapy. And this information therapy is a win-win situation. It's good for doctors to provide it. It's obviously good for patients to receive it. It's good for the entire healthcare system. It's a very inexpensive way for the government, for example, to make sure that care is provided and best is care which is appropriate. It's good for pharmaceutical companies. It's good for health insurance companies. So that's my last slide, is that it's simple enough. It's just the right information to the right person at the right time. And the great thing about it is empowers you. You're no longer dependent on your doctor or your professional. You understand that, yes, you can take care of your own problem. Because it's information therapy which is published, it's based on scientifically validated, evidence-based guidelines. So you know what's right, you know what's wrong. And equally importantly, it helps to reduce unnecessary testing and unnecessary surgeries. Because if the guideline says that just because you have heavy menstrual bleeding doesn't mean you automatically need a hysterectomy, a lot of patients will say, no doctor, I don't want a hysterectomy done, I want alternatives. That's our solution. Thank you.
Can we have the next speaker, Dr. Ratna Devi? Amit Solanke.
I would definitely agree with Dr. Malpani that self-care and need of a website for a doctor is important. Because I remember 2 years back I was working with one company called Hospacks, which is into projects, and they come up with hospitals, and they were talking about integrating all the nexus of doctors and bringing all the doctors on one common platform. So there was one initiative which we did was going to each doctor and telling them that we will open a website for you. You don't have to pay for it. Whatever pharmaceutical company offers you, you just have to extend it to the website alone. So you get a website free, whereas you don't have to pay for it. But in Bombay, I remember from Kolaba till Borivali, we had approached almost 65 doctors, and the figure is that only 20 people even showed interest in it. So it's very difficult for every doctor to have a website and convince that he should be having his own website. Talking about innovation, I would like to talk about innovation because everybody here is talking about disruptive innovation and innovation. And Alair Health, which is a part of Alair Incorporation, which is Boston-based company. We are a $2.3 billion company. We have two streams of revenue. One is a medical device, and second is a health management. We're present in almost 25 countries. And in India, we are present from 2007 onwards. We have around 250 employees. We are doing almost $50 million here in India. From January 1, we have started our health management division in India, which will be working on two divisions. One is on patient care, that's self-care, facilitating self-care, and second is providing technology, that is point of care. So when we talk about innovation, there are three areas of innovation in healthcare. One is customer oriented. When we talk about customer, it is client convenience, low cost, and affordability, accessibility. That has to be kept in mind in a customer. Second, we talked about technology. When we talk about technology, it has to be low cost technology, low cost drugs, and obviously a very effective IT platform which a layman, a common person can access. Third is a business model. When we talk about business model, it has to be horizontal as well as vertical. When horizontal means like what Dr. Malpani and other doctors in Bombay or anywhere, they have a horizontal platform. But all doctors come together forward and provide a community services to poorly driven. Because if you divide the entire healthcare industry, I divide them into three segments. One is a 2% which is very rich class, which are as rich as anywhere in the world. Second is a 30% middle class who are working in various corporations like us. And third is a 60% poor class who are completely dependent on the government for medicine. So, and then the second vertical is obviously the vertical integration of business model, where, for example, if I give example of diabetes, then all faculty and specialists, right from a diabetologist to podiatrist, ophthalmologist, all comorbidities has to be taken care under one shop, and which somebody coined a term called factories. So, but there are various factors and barriers for innovation in healthcare. One is the players. We have different players. We have big players, like there was the technology. I read an article where there was scientists who had come out with a nanocrystal technology for X-ray, which was basically taken from military. And because of X-ray being in the picture, and this was not licensed and the policy was not formed for it. Second part is funding. As Paul, organization like Paul, they need a lot of justification. Like we have a microfinance, we need to have microfunding also for people who are innovating and doing disruptive innovation. Then the policy obviously come into picture because any person who comes out with disruptive innovation, it has to be policy oriented, it has to be regulated. Then technology, customer and accountability. I'll go to the next part of it. Everybody is talking about disruptive innovation. I'll just take 2 slides of disruptive innovation. I just would like to tell you, this term, disruptive innovation, was coined by a professor in Harvard called Clayton. And he was talking about sustainable innovation and a disruptive innovation. I know most of you might be knowing about it, but this is for those who are not aware of disruptive innovation, who has coined this term, and how this disruptive innovation came into form. So all the big players, all the sustainable innovation or big innovation, they need to improve on a regular basis. Like Mahindra will come out with Scorpio now, Zylo. So this is sustainable innovation. Whereas disruptive innovation, which is low cost, which have a very low acceptance or need in the market, but still those innovation which can supersede a very strong player in the market. In healthcare, there are 2 sort of disruptive innovation. One is a disruptive innovation in an institution, where the focus from teaching hospital has come to outpatient clinic, and from outpatient clinic we are going to in-office care, that is X-ray from office to office. Now we are talking about in-home care. We are trying to provide everything at people's doorstep. So going from hospital or tertiary care and bringing 80% of population which is healthy to home care and office to office care is required in any sort of a disruptive innovation. When we talk about disruption of healthcare and profession, it is right from super specialist to a specialist. Earlier, CABG was since it's done by a cardiac surgeon. Now angiography is done by a cardiologist. So from specialist to primary physician, the primary physician care has come to nursing care, and nursing care, as Dr. Balpani said, has come to a self-care, and that is what is the future. A technology-driven self-care is the future of healthcare. So I'll just share a small video. What Alair has done. Can you hear the voice?
Within any population, the prevalence of diabetes is about 3 to 4%, with the average diabetic costing an employer thousands of dollars per year. But personal health support is not about the average diabetic. It's about helping the individual who has been diagnosed with diabetes. Employees like Suzanne, she is 41 years old, a type 2 diabetic.
Can you hear in the last?
She's not exercising due to her embarrassment and being larger than everyone else at the gym. Suzanne has been working with
Is this on video?
It's a 2 minutes video. Not even 2. I don't have much time.
levels using her glucometer. The data is then transmitted to a leader for review by a nurse scan manager. Should the results be abnormal, the clinician monitoring the device data will make a call to Suzanne to ensure everything is okay or determine if action needs to be taken. Suzanne and her nurse care manager speak regularly. Her nurse suggests that it might be beneficial for Suzanne to enroll in a health coaching program. Suzanne and her coach have several conversations and an online chat. She is also excited to learn about Lear's online healthy living programs and enrolls in the Healthy Diet program. Why is it that acute events always seem to happen at night? Late one evening, Suzanne suspects she is suffering from a bad flu. She has also skipped measuring her glucose. Not knowing what else to do, she calls the Alere 24-hour Nurse 24 nurse line. The triage nurse pulls up Suzanne's record, and in moments she knows all about Suzanne, who she is, what challenges she faces, and the details of her care plan. The nurse and Suzanne discuss the symptoms of low blood sugar and determine that Suzanne is okay for the moment. Suzanne is relieved. The next day, Suzanne's care manager receives a notification that Suzanne called the Nurse 24 nurse line, and she accesses Suzanne's record. The care manager calls Suzanne on her cell phone, and they discuss the importance of measuring her blood glucose levels throughout the day. Suzanne makes a commitment to her care manager that she will more faithfully check her blood glucose levels and fill her insulin regularly. Suzanne continues to receive regular calls from one of the nurse team care managers to monitor her progress towards achieving the goals set out in her care plan. There have been great changes in Suzanne's life. She's lost 20 pounds, she has reached her goal to reduce her blood glucose levels, and continues to set reasonable and manageable goals that she can reach so that she can keep lowering her blood glucose over time. Her insulin dosage has been reduced by half since the start of the program, and she continues to work towards her goal of increasing physical activity and making dietary improvements. Suzanne is now well on her way to managing her diabetes, which is a significant improvement in her quality of life.
So, this is what Alair does. It develops a program around various diseases, especially diabetes, cardiovascular, COPD, asthma. Now, what does Alair is and what it does, it's basically improve from preconception to end of life across entire spectrum of healthcare needs, wellness and prevention, disease management, case management, and specialized services. We support the entire health continuum. We serve in the areas of both diagnostics as well as services. We have an innovative platform called Collaborative Care Solution, which integrate the physician, the technology, the IT, the service providers. So we call it a collaborative care solution, focusing completely on patient-centric solution, targeting the right people. We have our own enrollment process. We have a broad database, broadest healthcare data, which we integrate in our Alair longitudinal records, which is personalized solution which we give it to the employee. Remote patient monitoring through a daily monitor. We have a daily monitor which is put at a patient home, and all the data from the devices are captured through Bluetooth. It comes to a console which is basically shared with the treating physician as well as Alair physician. This is the data reviewed by clinician. Then we have a software, we call it Apollo software, which has an interface with the client, the health coach, the physician. We do biometric monitoring through data link monitors. We have a mobile app which make it a very user-friendly application for recording data history, which does a care coordination of all, that is point of care, data, Alair functions. And the scope and impact is that we touch base with almost 200,000 active managed program. There are 680,000 active health portal user, 23 million individual cover for tobacco cessation. So these are all statistics globally which we do it. And that's it. We are basically committed to take care of patient. Our focus is completely patient-driven. And in India, we're trying to provide all the services in a cost of only 500 rupees per participant. This is what we're trying to achieve. Our first centers are going to come up from Noida, Delhi, and the second from Bangalore, Puram, by January 15th. So shortly we'll hear a launch from us, and we strive to achieve almost 50 centers by 2030. Thank you.
Thank you, Dr. Any questions?
This is employers will pay the 500 per employee per year.
There are two models here. If you see, start from screening. Basically, earlier is going to be an awareness management company where we create patient education. Those people who don't know, are 50 plus, that they have prostate, we'll create the prostate awareness campaign. If you're asking the source of revenue, up to screening it will be paid by the employer. Post screening it will be paid by the employee. And now we are working with some insurance company and brokers. We have just engaged our services with 2 insurance companies and the broker, and we are coming out with a very low cost model where we can provide them call-based reinforcement every day, where a nurse will call and remind a diabetic patient that today 8 o'clock, 8:30 you're supposed to take breakfast, please take a medicine. So this is what we want to provide in a 50 rupees call-based program for you.
Thank you. Sambit. Can I ask Paul to hand over the
Yes.
moment?
Excuse me. Hello.
I have the next speaker, Mr. Darius Padova, MD of Vital Health.
One more speaker to go after me. So we'll try to keep it short. What I want to do today is to talk about patient portals. Just giving a brief of who we are and what we are doing. The company Vital Health Software, we started initially with chronic disease management, moved into patient portals, and then into personalized health management. We are a young company, 5 years old, and our founders are Mayo Clinic and Neobar Foundation. The Neobar Foundation is trying to aim for social impact. Our companies are, had dual headquarters in Netherlands and US, and we have offices in India and Germany. So what's happening today? I think we also had this article, I think maybe just less than a week back in the newspaper. Chronic disease are here to stay. More importantly, they are starting to basically, the onset has started to come at a much younger age, and over the last couple of days we have had various people talking about how to treat chronic diseases, etc. One of the things has been talked about some various disease management programs, how to use technologies, etc. And people have spoken about it. An important part here is basically about patient empowerment, educating the patient. That's how it is also going to help in taking care of this. So what are the sort of healthcare drivers today which we see basically? Informed population, early onset of chronic diseases which has basically started, and people are now talking about preventive care, wellness, etc. rather than going in for reactive treatment. Demand for safety and efficacy. Progress which has been happening in every side, science, technology, again in information technology, where basically medical records are being stored, information is being exchanged across health networks. So what are the changes happening? I think a couple of speakers before me also spoke on something similar. People are basically starting to talk about from a medical part to going towards the wellness part. Again, not going in basically when there is a problem, trying to see whether things can be diagnosed earlier and can we get into a prevention. Rather than going to a care institution, people trying to see as to what can be done from home care, how can things be taken care of that. From a formal care, the model is also moving to informal care. Like we have been developing some applications where basically, for example, people suffering from a particular disease, they all can sort of join together and basically have their own chat groups, etc., where they can exchange their experiences, how things are being taken care of, people share their experiences. Also, more than caregiver decides, patient empowerment, patient wants to be knowledgeable, patient wants to do some more things proactively. We as a company also have a vision which is pretty similar. There are 4 parts which we are basically looking at. The first part being collaborative. What that means is the health records which are available, they can be distributed across various health networks. So if there are more than multiple caregivers taking care of the patient, information can be shared amongst all of them. Clinical pathways which should basically be coming up. Patients can basically talk with professionals. Also, as I mentioned, they can do something with their community as well. Onto a patient-centric scenario, what we are also starting to look at, it's not that patients are suffering from one chronic disease. There are people who are starting to suffer from multi-chronic disease. So what they require is basically to be able to do some self-management. Again, basically come up to some individualized medicines, individualized care plans, etc. Not something, initially things were basically pretty generic. Now individual care plans is something which is happening. On a knowledge-based side, what we are basically looking to treat is through protocols, guidelines, etc. Clinical decision support which can help the physicians to take knowledgeable decisions and through workflow. The other important thing is we are talking about proactive care rather than reactive care, and that's where we are basically looking at more of preventions and screenings, etc. So trying to diagnose the disease before a patient is actually getting into that and see what can be done to sort of delay the onset or avoid it. So we have various things like population management happening, health coaching. Collaborative care, the 4 things what I talked about, just to talk about it in slight more detail, is basically integrated support from within the network. So one is basically, for example, in terms of some mental health diseases, etc. The patient also basically requires help from friends, families, etc. who could support them. Also, we need to support this collaboration against the multiple caregivers which are involved in it. This information can be exchanged to the personal health records. On the patient-focused care, to focus on patients' individual needs. So coming up with personalized health plans, holistic approach to manage multiple chronic diseases which are coming in, help the patient to do self-management, the doctors could basically give support. Optimize use of social network. This is basically picking up where patients are trying to share their experiences as to how they've been able to cope with it. Evidence-based care. Again, here basically the treatment needs to be done on the latest guidelines and the healthcare innovation. So there is nothing like a treatment which can remain constant. I think almost every day new discoveries, etc. are happening. So things need to be updated on that. Promote the use of protocols using some smart software solutions. Again, integrated clinical and protocol decision support. Again, have the outcomes coming in from it and do some analysis as to what could be done better, and again have continuous improvements happening in this area. For a proactive care, start with a healthy lifestyle and prevention. Try to diagnose the diseases earlier, or at least understand when you are at risk and take the proactive steps. Things like disease management could also basically help you through health risk assessment, etc. as well, and improve of this quality. Now, what we basically look at, we were at a stage where the healthcare was mainly episodic, where patients only when they were basically sick going on to the doctors. Now, trend has started to change basically where more guided care is coming in, protocol based, evidence based treatment coming in, with clinical decision supports, etc. And the next steps are towards a personalized healthcare where the patient can basically be empowered enough to take his own decisions. As Dr. Malpani said, work with the doctors, but they are knowledgeable and they could sort of take their own decisions. So again, I mean, patient portal, I think almost everyone understands it, but just mainly to talk about, it's basically with various stakeholders who can come in, from physicians, nurse, from the office assistants, who can basically put in data which can go into the patient portal. This information can again be exchanged with various practice systems, health information systems, if there are any referrals, etc. The information has to flow across everything. Patient portal is not just entering data and that's it. That's not the patient portal thing. In what we see basically in Europe, patient portal adoption is basically has taken a step. I mean, there are countries where the adoption is basically happening at a high area, and adoption of patient portal is going to do few things. Again, small things like alert reminders to patient for the follow-up visits, doing the test, etc. at the right time. E-consults, people don't have time, maybe they can send information to the doctors, then can basically receive responses which would basically cut down their time, cut down doctors' time. And what we see basically now is that the patient portals, basically the adoption percentage is definitely going up much higher than the personalized health records. Now, just wanted to give an idea of the various patient portals which we have worked on. The idea more being to talk about the various functionalities, etc., which are covered up in the patient portal. Obviously, the first thing is education and interactive multimedia, where the patients can see some films, articles, etc. The information sharing basically which can happen, and the peer contacts and the social media, where, as I mentioned, groups can be formed where they can exchange information on their side. There are online appointments basically which are feasible, and then again, as I just mentioned, e-reminders for simple things like, okay, tests are due, follow-up visits are due. Again, e-consults and telehealth basically again taking a part here in quite a few of our patient portals. The initial part talking about is also about screening and assessment. So for example, the patients get a lot of questionnaire. Based on this questionnaire, when they reply back on the guidelines, there is a health risk assessment which comes up, and then basically they are guided into various clinical paths that, okay, I think these are the next steps which you need to do, these are the activities which need to be done. All this has basically clinical decision support and system generated diagnosis. We also basically have in the preventive services and some lifestyle coaching. Just want to basically show you some examples of the patient portals basically which we have developed. So here is one patient portal where basically it also comes up with a report. There's another patient portal which has been developed for the hospitals where, as I said, basically based on the questionnaire which is filled up, it comes up with clinical pathways. In this case, this is an online therapy for depression where people can come in on the web, can enter their information. And last but not the least, this is something where the health screening and wellness is done, and post that we have this scenario where basically the patient, once is diagnosed with something, there is a health coach assigned to it, and there is a personalized plan which is given to them. That's all I have on my side. Thank you very much.
Thank you, Mr. Darius.
Thank you very much.
I have the next speaker, Dr. Nicola Hanger from Italy.
Last speaker, so it's always a bit tough to keep attention. I thank the people who resisted up to now. I'll fly through. I mean, you've heard a lot of things during these days, and I think we are all aware of the problems that are out there. A bit different, a more aging population in richer states, with maybe a much higher number of care facilities and carers, younger population, but anyway a trend towards an aging, a problem linked to aging of people. Also here in India, if you look at the demographic projections, as you were correctly saying, we are going forward to having a problem linked to the people that are aging and are becoming old. So we are well aware of this problem. We are well aware of the issues linked to high costs of health. In Europe, we have been talking also about social care, which is a problem. Elderly people who are isolated do become very expensive healthcare cases. And you will see, I guess, this development here as well. You know, the family, daughter, son will have to go to another city to work. The elderly parents will remain isolated. Maybe they will have some friends, they will still have members of the family, but it will become more and more difficult to be there the whole time, available to support them. So we have tried to work on a concept that we call the e-health center. Basically, the idea is, you have heard about patient portals, you have heard about patients at the center. We have tried to elaborate on these issues. And what we thought, basically, it would be nice to have a single point of access. You have health and social problem. You would like to find somebody who helps you to solve your problems. Problems can be linked to chronic diseases, so you need a real disease management program, like the one you have described. So you are a high intensity, high maintenance, let's use this bad word, patient. So sucking up a lot of resources, requiring a lot of attention, but you might just be a worried parent, first child, you know, baby is crying, oh God, what is going on? At 3 o'clock in the morning, grandma is not there to tell you that it's perfectly normal. You need some sort of support. Or you need to do your blood test once per year at least to see that everything is okay and so on. So you need help to organize this different way of accessing healthcare. Our idea has been to start with telephonic services and IT tools. So to make life as simple as possible, you pick up the phone and you ask for the services you're entitled to, or we pick up the phone and we remind you. We remind you that maybe you have to do a vaccination. We remind you that maybe you're over 50. It's time to start doing some more proactive testing. We are reminding you that you should measure your blood pressure because you have hypertension, you have comorbidities. So with this idea of organizing access, we basically have taken over a whole set of different activities that you can actually manage remotely. So where we started 20 years ago was with what are called social care and telecare. It's alarm system, basically designed for frail elderly people who are living alone. They can start, to press a button and get a 24/7 call center that answers immediately, listens to what is the issue and tries to find the correct answer. Maybe it's a problem with the apartment. It's not necessarily a health problem. Maybe it's a problem with an appliance that is not working. So supporting the elderly person to find the right answer. So moving from here, what we have introduced is a proactive preventative screening. So again, no money or little money available, even in richer European countries. We're coming from Italy, so still not high spending as Germany or France, and now will be even less spending in the next few years, I assume. as you might all know from television. So, proactive. We call with a checklist. With a checklist and questions on social situation, on capability of surviving in your environment, so monitoring of activity of daily living and so on. And if you have diabetes, you have hypertension, on top of that, we check. We check if you are following a diet, we check if you are taking your pills, we check if you make a bit of movement. And we expanded from all this. So, from the alarm and proactive telephonic support, we started putting sensors at home to see if there were problems linked to gas, flood, temperature, and so on. We integrated the different social care providers and family and friends. So alert somebody there is a problem so you can make an intervention. Do something. Make sure that somebody is answering. And starting from this part of the population, we then saw two other big problems. One was that part of this elderly population had chronic diseases and needed much more intensive monitoring. So you have heard about the wonderful things you can do today in terms of is there somebody who's organized? Is it a single doctor that has, I don't know, 4,000, 5,000 patients that is looking at the data that are coming in from 1,000 of this, so 20% might have a chronic situation. Maybe another 5% have done a major surgical or intervention or had an acute care episode, and so for like 30 days or 2 months or 6 months, they need much more intensive follow-up. So the idea is that we work together with the local healthcare provider. We do not want to enter between the person and the care provider. So the person must choose whoever is the correct doctor, the correct acute care facility, whoever they want to talk to. What we want is to make this interaction easy. And we introduce what we call a model of management by exception. So we agree with the doctor what is the protocol for the specific patients, what are the thresholds, what answer to a question is indicating that there is a problem. And we describe an escalation model. So there is something wrong with the patient. We can schedule an appointment with the doctor. We can organize a conference call with the doctor. If it's an emergency problem, and the doctor decides that it's an emergency problem, we then evidently try to go to to activate emergency services. So this is one part of the problem. The other part that everybody is correctly reminding us is that you would like to keep a patient well. Because this part of intervention is, the machine at the car has problems. So we have to start spending money to repair it. If we remember to change oil regularly, check the batteries, and do all these nice things, the car might go on working for a much longer time. So what we do for general population, we are present as information gateway. So you need information about where to find the pharmacy, what kind of different specialists are available in the area. We organize appointments for you. We remind you, are you in a risk population, you need a vaccination, do you need some preventative test, because in the area there is some particular problem. So what we have is basically a call center with people that are skilled in managing different kind of care processes, but are not doctors. They don't do diagnosis. They agree with the care providers of the patient about what are the correct factors. We have software behind all this. So what we are doing is we are collecting the data from the patient. We are collecting this data together with the carer. We didn't do the step yet to allow the patient to set up the personal healthcare record. We had many discussions about this. We are looking forward to do it, but for us it was very important to have somebody together with the patient to check that the data that are input in the system are correct. This is not a minor issue. So you want at least to start with the patient where you're sure about what you're writing in the system, and then consequently what kind of processes you activate. We take care about integration. If there is anything else which is available out there. You know, you do your blood test, is there a laboratory information system? Let's make this data available electronically. You go to a cardiologist, consultant, you do ECG, you do something else. Let's have the reports at least available. So, call center, data integration, and we work on technology assessment. What kind of technologies can you give to the patient in order to make their life easier, in order to collect this data in a way to avoid error and to be effective? So just some numbers about what we're doing. I think it's important to look at the whole perimeter of services because you want to answer to the need of entire population groups. So from 5 million people that need active information on how to access healthcare and social care providers, to the specific 5,000 that have a chronic condition or need post-discharge monitoring, so they need a period of very intensive monitoring. We have answers that are targeted in terms of price and solutions to all these people. So again, one telephone number, and in the future, one patient portal for all this. You have to think that I liked very much the slide that the previous speaker showed. Personal healthcare records. The big problem is how to make sure that all the data that is out there is available to the personal healthcare record, and the data you collect gets transmitted outside. It's not a minor issue. Times probably you could consider that in countries where there is less of an IT infrastructure, it would be easier, and I expect in India it should be easier to start with this kind of approach, instead of Europe or the US where there are a lot of legacy systems and a lot of distributed data around. It's fine? Good.
How much more time?
Well, I can be reasonably fast. I don't want to keep people here.
We may not have many people here.
Yeah.
You can't go anywhere.
I know.
You are my hostage. So I'm holding a couple of hostages, but no, I'm nice. Come on. I have to worry about my debt, which is big being Italian. Just to tell you, the average age of people we are following at home is 83. We do more than 2.5 million calls per year. We have alarms that are medical. Only a minor part of this alarm leads to hospitalization. We have more than 50 patients who are over 100 and are living happily at home. So this is the kind of results we want to achieve with our support. When we organize all access to primary care, again, we have a reduction in hospitalization. So what you do is basically, we organize all access to GPs, nursing services. What we see is that you get a reduction in hospitalization, a much higher compliance in screening, examination, and preventative actions, and you get a reduction in referral to acute care specialist. So this is money you save, this is clinical results that you get. And I mean, the best way to save money with all these things we are talking about is actually making patient better. You know, good clinical outcomes. That's the way you save money. It's, all the rest is a bit of poetry. Telemedicine, we are working with about 5,000 patients, and what we get, for example, diabetes, reduction in glycated hemoglobin, reduction in cholesterol, reduction in triglycerides, reduction in hypoglycemia events. So it's important to sit down with the specialist or the primary care doctor that is following the chronic patient and see what are the targets that you want to achieve. You want to preset the targets. You don't want the targets to be a surprise that you find out at the end. All this needs, as I said, web-based software. Our way to the future, and here I am, is that you will be able to deliver a whole set of different home-based services, which will be more and more based on the personal healthcare record. But you will have also tools to empower your patient, and I very much like what you said, 80% of the results are due to the patient and not to the professional. And as you were saying, with a webcam, you can put a video on the web, even if it's not high definition and so on, but explaining what happens, what are the best ways for doing physical activity. Remember, chronic condition, physical activity, diet, remember to take your pills. You don't need a cardiosurgeon for this. You need some common sense, good communication, and these things should be available to patients. We are looking forward to move this activity and this model from Italy, where we are now. We are now opening activities in the UK, and we are looking forward to move to India in the next months with this model. Thank you.
Thank you.
Can I ask a question?
Yep.
So, you mentioned that you have a protocol for each patient, when to call the primary care physician,
Yeah.
etc. Which means that for each person who signs up with your service, you will have to sit down with his or her physician and design that protocol. Is it time consuming for the doctor?
Yeah, of course you need to sit down with the doctor and agree with him, but there is no way out of this. I don't think that there is any feasible way of making a realistic disease management or care management plan without talking who is at the end responsible for prescribing, who knows the patient because he already talked, several times, and who can tell the patient, listen, you do not really need to come here, sit 3 hours, wait to talk with me 2 minutes. In this way, we are sure that as soon as there is some signal that you are getting out of control, the system will react. I will call you, and you will not need to self-decide when it's an emergency or a problem. So it's true, it takes time to the doctor for patient enrollment, but it's the only way to make this, at least in our opinion, to make this kind of program reliable.
If doctors realize the value, they must be recommending the service to their patients on their own.
Yes. Our experience, if you try to do this, we even try to work with, for example, a private hospital. Say we take the patient, we have the people in the private hospital, the specialists, and we do everything. People go to their doctor. They have a doctor, usually, everywhere, in all nations. You don't go 1 week to one primary care and the following week to a different one. So either you work with the primary care doctor. Specialist, you can change the specialist. You need different specialists. You heard that there is a brand new cardiologist, Mark, who has studied at Harvard or whatever available somewhere. So you might want to try that one, but your GP stays there.
One more question. Do you get spurious calls? I mean, I imagine there are a lot of lonely senior citizens who just want to talk to someone. Do you get calls like that?
Yeah, we get spurious calls. We had, in this case, we get a contribution, so it's not only private payment, it's mostly public payment, because the citizens that are generating these calls, at the end, they, you know, if you have a problem at midnight on Saturday, the only place that is open 24/7 is accident and emergency. So, you know, your cat does not feel well, you end up in accident and emergency costing $1,500. Okay? So the idea is basically you can call us, we even find a veterinary for your cat, because we keep you safe at home. You are 83 years old, you want to feel safe. You know, you pick up, you have a problem, eating is not working, it's too cold. Even in rich Europe, Sunday night, the only place you land, unless your son is coming and solving the problem for you, you go to accident emergency. They won't throw you out, you're 80 years old, come on. Who's going to throw you in December out on the street with snow and everything? So you become suddenly that cost center that is making healthcare costs tremble and go up at double-digit growth rates.
Thank you. That brings us to the end of the session and end of this day. Thank you for staying along so